Good afternoon. I'm Dr. Arthur Goldstein. I am the medical director of the Olean General Wound Care Center. This afternoon, we're going to be talking about discolored legs, how to diagnose patients who have discolored legs, and what the discolored legs might mean. When we talk about discolored legs, we're pretty much talking about erythema, redness, or what I like to call as rubor. And the first topic we're going to talk about is venous disease. Here's a typical example of someone with venous disease. Legs are swollen and discolored. They've got a little bit of a red color to them, but they've also got a little bit of a purple color to them, making them appear more ruborous than anything else. So what do we normally see in venous disease? Typically, the patients who come to us, the history is chronic and long-standing. They'll usually have edema, maybe some discomfort and pain, tends to be worse towards the end of the day, and it tends to be improved if they would elevate their legs or use some form of compression therapy. Obviously, elevating and using compression therapy will relieve the edema. Most of these patients do not have a history of deep vein thrombosis, and the classic venous disease is really due to what we call venous insufficiency. If a patient ever comes into you with chronic venous disease and they've got what we consider an acute unilateral exacerbation, where the pain is just out of proportion and the leg is really swollen, you have to check that patient for a deep vein thrombosis. That can be superimposed on this acute presentation. Some of these patients, most of the ones that we see in the wound care center, will have ulceration of their legs or weeping skin. And usually this presents itself in what we call the gaiter area, which is sort of the medial ankle area above the medial malleolus. We'll take a look at some pictures coming up later on in the slides here. The mainstay of treatment is compression. In the center, we will initiate compression with Uniboots and a variety of other compression wraps, eventually changing patients over to Velcro garments, which have become very popular. We used to use compression stockings, but a lot of the older patients, they have arthritis, they can't get them on their legs, and these new Velcro garments make compression long-term for these patients much, much easier. Before you initiate compression therapy on anybody, you should really check them and rule them out for arterial disease. We will do that by doing a PVR study. Remember, 20 to 25% of patients with venous disease will also have mixed arterial disease. Typically in our patients, venous disease represents 30 to 40% of our patient population. And again, here's a typical patient. It's bilateral. It tends to be symmetric, kind of a ruborous purple color with some edema. As this disease progresses to a more chronic phase, we will see patients in our clinic that have this typical presentation. And this is called Demato Liposclerosis. The leg resembles, if you will, an inverted champagne bottle, where the bottom portion of the leg around the ankle has so much scar tissue that it no longer swells, and most of the swelling is confined to the upper leg. These patients are very prone to minor trauma to the skin, which will cause ulcerations, as we're seeing in that first slide. How does venous disease differ from patients with cellulitis? They both tend to be red and ruborous. However, cellulitis presents as an acute illness as opposed to venous disease, which tends to be chronic and long-standing. Cellulitis is almost unilaterally a disease of one leg. 90% of the patients will present with a unilateral process, whereas venous disease is bilateral. With cellulitis, you'll almost always have what we call a prodrome of systemic symptoms: malaise, a headache, body aches. They almost feel like they're getting the flu. And then they'll break out usually with shaking, chills, and a fever. Also with inflammatory signs: erythema, warmth, tenderness, and pain and swelling. There's oftentimes a sharp demarcation of the edema. Usually we see this with a condition called erysipelas, which is very typical of streptococcal cellulitis. 50% of cellulitis will be from streptococcal disease, with another 25% or so due to Staphylococcus. Those are the most common microbial agents. When you see one of these patients, don't forget to examine the foot and the toes, particularly in diabetics. Fungal dermatitis is very common. Maceration and ulceration between the toes can often be a precipitating cause. And don't forget to look for an abscess somewhere on the lower leg or foot. Here again, two patients with classic cellulitis. It's well demarcated, particularly the picture on the right-hand side is a picture of classic erysipelas, sharply demarcated erythema. And again, one last patient with cellulitis. It's unilateral. The leg is swollen, red, and warm. And you could see that little dressing that the patient has on their toe. I bet there's a nasty ulcer or a bad toenail underneath that dressing. Don't forget to remove the dressing. I threw this slide in here because this particular patient kind of looks like our venous disease patient, but many physicians will mistake this for bilateral cellulitis. And remember, cellulitis is invariably a disease of one leg. This particular patient came into our center with underlying venous disease, and we put them in Uniboots. And unfortunately, they had a contact allergic reaction to the Uniboots. And what we're looking at here really is contact dermatitis. The key here is the history and the fact that the patient is itchy as all heck, having severe pruritus to the area. Treatment here obviously is stopping the Uniboot and maybe a topical steroid, along maybe with a antipruritic medication like Benadryl. Another patient that can be easily confused with a bilateral cellulitis. This patient came to us with an acute exacerbation of her lymphedema. The history here is key. There's no prodrome, there's no fever. If you happen to get labs on this patient, the white count's going to be normal and the differential's probably going to be normal. Again, the history tells us that this process started weeks ago with initial swelling and then became even more swollen with symmetric erythema. Acute lymphedema can cause erythema of the legs. We see this a lot in our clinic. Like venous disease, treatment here is primarily compression therapy. This patient was placed in compression wraps and immediately began to feel better. I want to thank you for listening today. That concludes our talk. If you have any questions, please feel free to contact me over in the Wound Care Center. I'll be happy to answer anything that you need to talk about.